So hello everybody, my name is Uwe Platzbecker and I'm just at the annual ASH meeting in Orlando. Just attended a very interesting session on novel therapies in AML. David Steensma presented a study on a spliceosome modulator, H3B, in high-risk MDS and primarily AML patients refractory to standard of care treatment. The way this spliceosome modulator is considered to work is that we know that in many patients with AML and MDS that many of these patients harbor spliceosome mutations. They are actually only on one allele of the gene, so it leaves actually one allele unmutated. So these cancer cells, these leukemic cells, have a mutated and an unmutated allele of the spliceosome. And actually these cells can live quite well with this spliceosome mutation. It may even give them a growth advantage towards non-leukemic cells. So therefore the concept with the spliceosome modulator is to inhibit the still remaining healthy or intact spliceosome apparatus. And in vitro data basically show that if you do that, the cell only relies on the mutated spliceosome, and this leads to a so-called spliceosomal sickness. So the cell is actually getting sick and cannot survive and is selectively depleted by this spliceosome modulator. Although the drug showed some pharmacodynamic effects, so spliceosome was actually targeted in the study, it was not very efficacious. So very moderate response rate as a standalone, as a single agent. Well, the reason for this is not quite clear so far, but I think it still opens the window for combination therapies, and I think that the drug may be an appealing option for future clinical studies, combination with standard of care chemotherapy or even hypomethylating agents.